Hello everyone. In this topic, I will talk about anesthetic management in obese patients. Now, obesity has become a global epidemic. The incidence of or prevalence of obesity has kind of tripled over last 40 years. So, in your routine anesthesia practice, you will very often come across obese patients. So, how do we manage them? What are the important factors that we need to consider in their preoperative assessment? In their pre-anesthetic evaluation, what are the important risks associated in them for when they're coming for surgery? How do we assess the risk in these patients? What are their perioperative management? What are important post-op care we need to take in these patients? All the things we will discuss here. Apart from that, I will also tell you a little bit about the physiological changes which happens to the major organ, respiratory and cardiovascular system in obesity. That would help us in our understanding of managing these patients. Now, as I told, obesity has become a global epidemic, and highest number of obese people or highest percentage of obese population is present in the United States. Now, 88.5% of their population is overweight, and 32.3% of their population comes under obese category. Now, India is not far behind. Now, the prevalence of obesity in India, right? Obesity and abdominal obesity in population is 13.85% and 57.71% respectively. So we have more of abdominal obesity, that is central obesity, which I'll talk about, and that is bad, more bad than your other kind of obesity, right? So central, we are more prone to central obesity. So definitely in your routine anesthesia practice, we will come across the obese patient, and we should know how to manage them for minimizing the morbidity and mortality. Now, the definition, the classification of obese in super obese or super obese or morbid obese, they all have become obsolete. Now, I will discuss with you the classification which is based on body mass index. Now, though I'll talk about body mass index is not a very, it's a common way of measurement of obesity, common way in measurement of obesity, but it is not a very, let's say, sensitive index which will tell us the risk associated in these patients. But still the classification done by WHO and the risk assessed through ASA classification is the latest one which we need to discuss. So what I am talking about is body mass index, right? That is BMI. So this is a commonly used in obesity. So commonly used measurement in obesity. What is the advantage? It is very easy to calculate. The advantage is easy to calculate. Now, what is the problem of thinking just about BMI? It tells us about the body mass index. It categorizes the patient into according to weight, but it does not tell us about the distribution of the fat. I talked about central obesity. I'll talk more about it. So that is more bad. So BMI does not give us an idea of distribution of fat, right? Neither it tells us about the association of some metabolic syndrome which is present in these patients. So that is why it is not very sensitive, but still it is one of the commonest way of classifying the obesity. So it does not describe composition and distribution of body tissue, composition and distribution of body tissue, that is muscle and adipose tissue, or metabolic state. What is the metabolic state? But still it is the commonest way of classifying the obesity, and definitely it is useful. It's a useful indicator of planning and preparation in these patients. So let us discuss how do we classify obesity on the basis of BMI. This is WHO classification, and ASA risk has been the concerned ASA risk is also in this classification. So categorization of obesity, right? The normal weight comes under the BMI 18.5 to 24.9. Less than 18.5 is your underweight. Less than 18.5 is underweight. And more than 24.9 comes under overweight. So 25 kg per meter square onwards, it's overweight. But obesity is defined more than 30 kg meter square, right? And then it is classified into three: class 1, class 2 and class 3. Class 1, class 2 and class 3. According to the BMI, 30 to 35, 34.9, between 30 to 34.9, it is class 1. 35 to 39.9, it is class 2, and above 40 is your class 3. And the ASA grading 2 and 3 has been given to class 2 and class 3. Class 3 comes under ASA grade 3, class 3 obesity. The rest all comes under the ASA grade 1. Okay, so this is ASA grading and classification of let's say your obesity on the basis of your BMI. Okay, now we will keep this in mind. Okay, now let us little bit talk about the physiological changes which happens in obesity. This would be helpful in our understanding the physiology and managing these patients. So first, let us talk about cardiovascular system. So what happens? What does the excess body fat do? Now, excess body fat increases the metabolic demand, and this increase in metabolic demand would increase the cardiac output. And after a certain increase, to increase the cardiac output, neovascularization will happen. All this will increase the blood volume and it will also increase the load on the heart. So, the important cardiovascular changes. So, what happens? The excess body mass increases the metabolic demand. Metabolic demand. So, when metabolic demand increases, cardiac output has to increase. Now, increase in cardiac output happens. How much? 0.1 liter per minute for each kg of fat. For each kg of fat. Okay. So, there is increase of 0.1 liter per minute of cardiac output for each kg of fat. And for 13.5 kg, for every 13.5 kg of the fat, neovascularization starts in the body. So, for every 13.5 kg of fat gained, this would lead to neovascularization. Neovascularization. So, this increase in cardiac output, increase in cardiac output would increase the workload of the heart. So, workload will increase. So, left ventricular hypertrophy. Left ventricular hypertrophy. This will lead to left ventricular hypertrophy. And since the blood is increasing, so pulmonary blood flow will also increase. So, there would be increase in pulmonary blood flow also. Increase pulmonary blood flow. And this increased pulmonary blood flow would cause pulmonary hypertension. Pulmonary hypertension, which would lead to cor pulmonale, right ventricle, heart failure, right-sided heart failure. So, pulmonary hypertension, cor pulmonale, and right-sided failure. Right-sided failure. So, the left ventricular failure and the right-sided failure both can happen. So, just a flow chart. What happens in obesity? In obesity, there is increased in the total blood volume. This increased in the total blood volume increases the cardiac output, which increases the left ventricular workload. This causes left ventricular hypertrophy and left ventricular failure. Apart from this, with obesity, lot of other comorbidity is also associated, like your systemic hypertension and ischemic heart disease, etc., which will also contribute in the left ventricular hypertrophy and left ventricular failure. Okay, and what will happen to the right side of the heart? There would be increased pulmonary blood volume. So, pulmonary hypertension, increase right ventricular workload. So right ventricular hypertrophy and right ventricular failure. So there would be biventricular failure, which can be seen in obesity. Now, pulmonary hypertension can also be exaggerated by the association of obstructive sleep apnea and obesity hyperventilation syndrome, which causes hypoxia, and hypoxia causes pulmonary hypertension. So, the associated comorbidity of obesity, the respiratory and the cardiac, would also make the changes in the heart more and more, let's say, increased, and there is a risk of biventricular failure. Okay, so this is the effect on cardiovascular system. Now let us see the effect on respiratory system. What happens in the respiratory system? Well, before that, just see this diagram. Now let's say we have a lean normotensive patient who have a normal preload and afterload. What happens in hypertension? The afterload increases. So if it is a lean hypertensive, normal lean hypertensive, not obese, afterload will increase. So afterload increases. The preload remains the same. So there is a hypertrophy of the heart, right? In obese, what happens? If the obese is not hypertensive, what happens? The blood volume increases, so the preload increases. Preload increases, but afterload is normal. So there is the dilatation of the heart, okay, because of the excessive work which is there on the heart. But in case of obese hypertensive, both the preload because of the obesity increases and afterload because of the hypertension increases. So both increases. So dilatation and hypertrophy of the heart, and there is a risk of congestive heart failure. So there is a high risk of congestive heart failure. Okay, this congestive heart failure can be more exaggerated by the comorbidities which is present in obesity, like systemic hypertension, ischemic heart disease, right, obstructive sleep apnea, obesity hyperventilation syndrome. So all this would further deteriorate the condition of heart. Okay, now let us see, as I told, respiratory system is the another system which we need to know what is the effect, right? uh, Muscle strength in obese patient, the lean muscle strength decreases. So respiratory muscle efficiency is below normal. So respiratory muscle efficiency is below normal, right? Then there is decreased chest wall compliance and lung compliance. So during ventilation, we may need a higher inspiratory pressure to ventilate these patients. So it may require higher peak inspiratory pressure for ventilation. Then in obesity, there is a decrease in the lung volume and capacity. What happens? The functional residual capacity decreases, the vital capacity decreases, and the total lung capacity decreases, right? The functional residual capacity decreases, it goes below the closing capacity. So reduced FRC, it goes below the closing capacity. So what will happen? Atelectasis. The risk of atelectasis, small airway closure, is increased, and there would be increased ventilation perfusion mismatch, okay, and more hypoxemia seen in these patients. So arterial oxygen tension may be less in the obese patient at room air. So in obese patient, the arterial oxygen tension would be less when they are breathing room air, and this would be one of the marker of the severity present in these patients, right? Association of your obstructive sleep apnea and obesity hypoventilation syndrome is more in obesity. There is association, and this can further make the airway also of the patient difficult, and would further decrease the respiratory efficiency, and would also contribute in cardiac dysfunction, right? So this is the two main organ system, cardiovascular and respiratory. Now just a special mentioning of few more organs, like but before that, see this image. How does the obesity affects the decreases the FRC? How the relationship between FRC, functional residual capacity, and the closing capacity, in how does it changes in a normal and in an obese patient. In a normal people, the FRC is much above. This is the FRC and this is much above the closing capacity. So let's say this is the closing capacity, the volume below which the alveoli would start collapsing, right? So this is the closing capacity. Normal individual, the FRC is above the closing capacity, right? Non-obese. Obese upright, the FRC starts decreasing, FRC starts decreasing and it starts going below the closing capacity. Well, obese supine, this further FRC further decreases and start going further below the closing capacity. And obese in Trellendenberg position, right? In Trellendenberg position, the more FRC reduces and more it goes below the closing capacity. So more is the risk of ventilation perfusion mismatch. So obese upright also, there is increase, the FRC reduces and closing, it is below closing capacity. So there is hypoxemia at room air also in obese upright patient. But when the obese patient goes in supine and furthermore in Trellendenberg position, the risk increases even more. So as I told you, that since they have decreased chest wall compliance and lung compliance, peak inspiratory pressure required to ventilate them would be increased. And because their FRC goes below the closing capacity, application of PEEP would be very helpful in these patients to prevent atelectasis and ventilation perfusion mismatch. So application of PEEP should be very much considered in these patients during ventilation. Application of PEEP would help and prevent the ventilation perfusion mismatch in these patients. Okay. Now some few more organ systems we will talk about. Let us talk about the coagulopathy which is associated with the obesity. Now your adipose tissue, it has large number of bioactive mediators which causes the abnormal lipids, increase in abnormal lipids, insulin resistance, inflammation and coagulopathies. So what does it do? It causes it, because of these bioactive mediators, the fibrinogen level increases, factor 7 level increases, factor 8 level increases, and von Willebrand factor, plasminogen activator inhibitor 1, everything increases, and this causes hypercoagulability. So your obesity is hypercoagulable state. Hypercoagulable state. So the risk of thromboembolism increases. So in these patients, the risk of thromboembolism increases, right? Okay. Now, next system, gastrointestinal system. Now, they have gastric volume and acidity is increased in these patients because of delayed gastric emptying, right? They have a delayed gastric emptying. They have association of hiatal hernia and they have association of gastroesophageal reflux. All this can increase the gastric volume and decrease the gastric pH and increase the risk of aspiration. So it can increase the risk of aspiration in these patients, right? So risk of aspiration increases. So we will discuss the role of RSI in these patients. And there is high prevalence of non-alcoholic fatty liver disease in these patients and non-alcoholic steatohepatitis in these patients and cirrhosis in these patients. So liver dysfunction is also very commonly associated in obese patients. Okay. Now, apart from the let's say changes in the physiology, the metabolism of the drugs in obese patient also changes, and we need to know about the changes, and then how, because of let's say managing the dosing of our anesthetic agent, how to do the proper dosing of our anesthetic agent in obese patient, right? So, what have the volume of distribution of the drugs in obese patient changes because of several factors. Now, their body weight increases, their total body water also increases. So total body water increases, right? Then in the total body fat increases. So lipophilic drug, they may get more and more concentrated in this high volume of fat. So what will happen? They will get stored in the fat, and so let's say metabolism of these drugs would be affected, and there would be delayed offset, delayed recovery from the fat soluble agents like your opioids and all. They are highly lipophilic, your fentanyl, your remifentanil, etc., and they may get stored in the fat. And when they get stored in the fat, the offset from these drugs, the contact sensitivity half-life increases. So recovery would be delayed. Then there is increased in lean body mass. If there is increase in lean body mass, their total body mass increases, their fat mass increases, their lean body mass also increases. Because of increase in lean body mass, which is less compared to the fat mass, the metabolism of drug little bit increases. So fast clearance of drug is seen compared to normal population. Then there's altered protein binding because of the increased blood volume. There's increased in cardiac output in these patients, as we talked about in cardiovascular changes. And because of increase in cardiac output, especially they affect the inhalational anesthetic agent. The induction would get a little bit slowed in these patients. We have talked in the topic inhalational anesthetic agent. Increased cardiac output slows the induction. So increased cardiac output would slow induction with inhalational, right? Apart from this, they have increased blood concentration of free fatty acids, triglycerides, cholesterol, alpha-1 glycoprotein, which would affect the binding of the drugs. And number of times free drug would be more present in the plasma because of the altered binding, or maybe decreased in the plasma because of the altered binding, depending upon the drugs bind to which plasma protein. Then it also depends upon the volume of distribution, also depends upon the lipophility and hydrophility of the drug. The lipophilic drugs, they have more volume of distribution, they are distributed more, and hydrophilic drug, they have a lesser volume of distribution. So hydrophilic drug, lesser volume of distribution in obese patient. If we will give the drug according to the total body weight, they would be more present in the plasma, and the risk of toxicity with these drugs would increase. Then because of the organomegaly, also the metabolism of the drug is affected. So because of this change in the volume of distribution due to these factors, what happens exactly? There's increased redistribution of the drug, and it prolongs the elimination half-life, particularly of lipophilic drugs, right? Even when the clearance is increased or maybe unchanged. Now, metabolism of the drug is not affected because phase 1 metabolism and phase 2 metabolism is not affected in obesity. But the renal clearance of the drug is increased because of increased blood volume, right? Drug dose, how we calculate. If number of times, if we calculate the dose of drug according to the actual body weight or total body weight, there would be excessive plasma concentration because of low volume of distribution of some of the drug, and the risk of toxicity will increase. So we have to see how do we calculate it. And repeated injection of the drugs, that is continuous infusion, especially for the maintenance agents, can cause accumulation of drug in the fat, especially for your benzodiazepine and all like midazolam, which gets accumulated in the fat. So offset of these drugs would be definitely delayed in obese patient. Okay, so how do we dose the drug? Now, dosing of the drug, to understand the dosing of the drug, you need to know about how the body weight is calculated in these patients. So you need to be familiar with the terms like total body weight, your lean body weight, your ideal body weight, your adjusted body weight, your predicted body weight. You need to be familiar with these terms. Okay, so I'll just make you familiar with these terms. Let us talk about total body weight. Well, as the term says, it is the actual body weight, what the person weighs on the weighing machine. So that's the actual weight. Well, when in a normal person, the total body weight of the total body weight, now 20% is fat weight and 80% is the lean body weight, right? So when total body weight increases, right, in obese, fat weight increases more and lean body weight also increases but less. So total body weight to lean body weight, the ratio increases in obese patient, right? The ratio increases. So what is lean body weight? So lean body weight, ideal body weight, predicted body weight, they are calculated according to the height and the sex of the person. So it is calculated according to the height and the sex of the person, right? But in obese patient, number of time they have high, let's say they have a high they have high fat concentration. So number of drugs, they, if there it is given by the lean body weight. It may not achieve the plasma concentration, especially the drugs with a low therapeutic index. It would not achieve the plasma concentration. For them, there is something called adjusted body weight, which is calculated by adding into the lean body weight the little adjusted body weight according to the fat present in these patients, right? Okay, so ideal body weight, this is calculated according to, this ideal body weight is weight based on height, width, and BMI considered is 22, right? The ideal BMI is 22. Considering the ideal BMI, this is the weight calculated according to height, right? So what the patient should weigh with a normal ratio of lean to fat mass, and it varies with age and is usually approximated to the function of height and sex. So this is the formula to calculate the ideal body weight. Now lean body weight is your again the weight which is calculated according to the height and the sex. So this is the weight of the patient excluding the fat. So total body weight